I'm going to talk about today COVID in the economy. And as I talk about this, please keep in mind I'm an economist. I'm I don't know about the medical side. I'm not an epidemiologist, but I am a data analyst. So I'll tell you about the data as I perceive it to exist. But when it comes to making statements about COVID as a disease, that's beyond my expertise. So I want to focus more on the data that came through and the economics that's going on in the background. And this story starts with the threat, which is COVID itself, and then I claim there was a misunderstanding initially. And this misunderstanding led to a policy response that might have been different had the misunderstanding not existed. And this policy response was picked up by the media, which created a mischaracterization. And these two things, the policy and the policy response and the mischaracterization, fed back on each other in a way to give us an outcome that, had we sat back and thought about it more carefully, we probably would not have chosen. And then finally, all of that leads to some economic effect that I'll talk about. So let's start with the threat, COVID itself. This was a new disease, and so we were making things up as we went along necessarily because we didn't understand the disease. And the initial estimates as of March 2020 was that the infection rate was around 40 to 80%. That is, 40 to 80% of the people who were exposed will become infected. Now, contrast that with the common flu that comes around every flu season. And there, the infection rate, of course, it varies depending on what year and the circumstances, but the infection rate there tends to be around 10 to 20%. So right off, this is a disease that is 4 times as infectious as what we're used to with the common flu. And then, again, in March of 2020, the estimate was that the infection fatality rate was above 3%. Infection fatality rate is the probability of dying given that you have caught the disease. So infection rate, think of that kind of like as the probability of catching the disease, the probability of passing the disease on. Infection fatality rate is the probability of dying once you have been infected. For comparison, the infection fatality rate for the common flu is anywhere from 0.05% to 0.1%. So COVID was this thing that was far, far more deadly than the common flu and much more infectious. And if you just take those estimates that we had as of March of 2020 and apply them to the United States, a population of 328 million people, well, that tells us that we should expect 130 to 260 million infections and 4 to 9 million fatalities. So almost 10 million people dying of this disease. Contrast that with the common flu, which of course comes around every year, but the number of fatalities due to the common flu in a bad year is 70,000 versus the almost 10 million that we were anticipating from COVID. So this is what COVID looked like to us back in March of 2020. The disease that was anywhere from 100 to 200 times more deadly than the common flu. And so given that, you can start to imagine how reasonable people's responses were to this thing. But the problem here is that there was a significant misunderstanding. And the misunderstanding came from the fact that this was a new disease and we didn't have many tests for it. And the few tests that we did have, we reserved for people who were particularly sick. So we did not conduct randomized testing. We did not go out into the population, just randomly test people and figure out what fraction of the population has COVID and what fraction is dying of COVID. And so our understanding, which I claim is a misunderstanding, came about because the only people we were testing in the early days were people who were sick enough to show up at the hospital in the first place. That is, we were getting a biased sample of the population, and it was biased toward the sick, right? So imagine if you had done something else. Imagine if you asked the question, okay, what fraction of the population is suffering from broken bones? And instead of going out and surveying the population at large, instead you go to a hospital and survey people there and say, how many people here are suffering from broken bones? And of course, you're going to get a much higher number because there's a selection process. The people who go to people with broken bones typically go to the hospital. So you're more likely to find them there than you are to find them out in the general population. And so too with COVID. We were testing the people who were sick enough to show up at hospitals. And we were basing our estimates of the infection rate, the fatality rate on those numbers. But those numbers were biased towards sick people. And so it seems that because we were looking strictly at sick people, our estimate of the infection rate was too high by anywhere from a factor of 4 to a factor of 10. It also seems that our estimate of the fatality rate was too high by a factor of 2. Now, even when you make adjustments for this, COVID still ends up being a very deadly disease, more deadly than the common flu. However, it seems not to be nearly as deadly or nearly as infectious as we thought back in March of 2020 when we were making serious decisions for the economy, like should we shut businesses down? So we have a policy response based on this initial data. And what happened here, and I don't know whether it was deliberate, some people will say it was, some people will say it was just lucky chance, but what happened is the federal government did not have a unified response. And that's actually probably a good thing because the federal government didn't have clear authority to act in this instance anyway. Now, some people will say, well, yeah, but this is an emergency, so the federal government should act anyway. Well, it turns out it was actually better that the federal government didn't act because, as you'll see in a second, the implications of COVID vary dramatically from place to place. And so a better thing to do here is to respond at the state or even the local level rather than at the federal level, where you tend to impose one solution that may fit some people but doesn't fit others. And so we had our responses that varied by state. And so depending on the state, depending on the city, they would prohibit large gatherings or shut down businesses that dealt with the public, or they require masks. Some places still do, some don't. And all of that was intended to last for just a few weeks. If you go back and look at media reports back in March, early April of 2020, what people were saying was these prohibitions on gatherings, the shutting down of the businesses, this is just for a couple of weeks to, and they use the following words, to flatten the curve. That is, to make sure that our hospitals are not overwhelmed with more people, more sick people than they can handle. So this was something that was supposed to only last a couple of weeks. Now, while the stated goal was to make sure that we didn't overwhelm our hospitals, it turns out that the average hospital occupancy rate in the US never rose above 67% throughout COVID. And 67%, of course, it varies from time to time under normal circumstances, but 67% is about as high as it normally goes under normal circumstances. And so if you look at the hospital occupancy rate, so the number of beds that are taken up in hospitals, you can see it rises a bit during the age of COVID, but it never gets above this 67%. And so on the one hand, you could say our fears were unfounded because our hospitals were never inundated with patients. They were never in any danger of being inundated with patients. And that's true at the aggregate level. That is, when you talk about hospitals throughout the United States on average. But it's not true when you talk about specific hospitals. So hospitals in Washington State, for example, In their larger cities, they got up to 100% occupancy rate. Hospitals in New York City similarly got very high into the 90% occupancy rate. There were other hospitals out in the Midwest whose occupancy rates were remarkably low. And so this goes back to my statement that it was probably a good idea that we did not have a federal response, because a federal response would have imposed whatever the response is, this same single response on everybody. Instead, what we see is that COVID affected different areas differently. The high population areas, the big population centers, had a very different experience with COVID than did much of the rest of the country. And so keeping our policy at the state or the local level was probably a good idea here. So that's a misunderstanding due to the fact that we just simply didn't have the data, and we were not able to conduct randomized testing. But this lack of information led to a second problem, which I'll call mischaracterization. And what happened here is that the media started to mischaracterize the nature of COVID. And so they would give daily death counts. And so all the way back into April 2020, they'd have on the news every night, this many people died from COVID today. And people see that day after day after day, and the numbers are in the high hundreds or thousands. The average for April was 1,300 deaths per day. And you see that day after day after day, and it starts to hit you. You say, oh my God, this is a horrible thing. Look at all of the people who are dying every single day from COVID. And so people reacted to the media's characterization of what was going on. Except the problem here is it was a mischaracterization. That's not to say the media was lying. They were absolutely correct that so many hundreds of people died every day from COVID. The problem is they didn't give us any perspective. And the perspective is, on a regular day with no COVID, about 8,000 Americans die every single day. And I argue that what was happening here with people seeing these death counts on the evening news and getting upset about them, yeah, on the one hand, you should get upset about them because these are hundreds of people dying of COVID. But much of the upsetness, I argue, was simply due to the fact that people didn't know how many Americans normally die every day. And if you understand that every day about 8,000 Americans die from various causes, and you see 800 people died of COVID today, okay, that should be some cause for concern, but you shouldn't lose your mind about it, because that's 10% of the number of people who normally die per day. So it was this perspective, the context that the media didn't give people, and consequently caused people to overreact. Also, the media pointed to exponential growth. As the number of cases grew, as the number of deaths grew, they'd show pictures and they would show this exponential growth of the number of deaths, the number of cases, and people see that and they wig out, because you see this exponential growth and you think to yourself, oh my God, if this keeps on, in a month, everybody's going to have COVID. In 6 months, everybody's going to be dead of COVID. Okay, but there's again some missing perspective. And the missing perspective is that exponential growth is normal for infectious diseases. It's as normal as the inevitable decay. That is, infectious diseases always follow this pattern of initially exponential growth, then they'll top out, then they'll decay. They don't go to exponential growth and just keep going to infinity. That missing context caused people who might otherwise be somewhat concerned, but not overly concerned, to become overly concerned. The media reported hundreds of thousands of deaths. So, as people got used to the number of people who died today, the media started reporting total deaths since COVID began, because those are bigger numbers and people can get more excited about them. And they would report hundreds of thousands of COVID deaths. I think as of today, the total number of COVID deaths in the U.S. is somewhere around 650,000, 700,000, somewhere in that range. Tremendous number of people who have died of COVID. Yeah, but here's the missing perspective. The number of people who died of COVID is actually smaller than the number of people who die of other diseases on a regular basis. Heart disease, cancer comes to mind. Heart disease and cancer deaths are something like twice the number of COVID deaths on an annual basis. And whereas COVID was kind of like 1 year or maybe 2 years and you're done, heart disease and cancer is year after year after year after year, decade after decade after decade. Every single year, the number of deaths being twice as much as COVID was for just the 1 or 2 years that we would end up having it. And so what's the effect of this mischaracterization? The effect of the mischaracterization is public support for the lockdowns. So the initial reaction, let's lock down the economy, let's close small businesses, we're only going to do this for a couple of weeks to flatten the curve. And the media gets hold of numbers and starts reporting them without giving people perspective. People start to wig out. And so they turn to their politicians and they say, yes, thank God you're locking down the economy. Keep doing that because look at all the people who are dying of COVID. And so this puts politicians in a very weird position where the politicians, even if they know that COVID isn't the huge deal that the media is making it out to be, the politicians have an incentive to act as if it is a huge deal because the people they answer to, the voters, believe it's a huge deal. And so this is this weird feedback mechanism that you get amongst the media and the politicians and the voters. And where does this mischaracterization come from? Well, it turns out the media has a profit incentive to report bad news. We like bad news. And how do I know this? Because when you see bad news, you'll click on it or you'll turn the channel to watch it. When I show you good news, people might say they like to hear good news, but the fact is, if you look at their behavior, they don't. If I show you good news, you'll turn the channel. It's not interesting. You won't click on it. It's not exciting. The bad news, that will get your attention. And of course, if it gets your attention, it sells advertising. And that's how the media makes their money. So the media here has a profit incentive for reporting the bad news. And so what happens? From April to May of 2020, the media focuses on deaths. They're telling us every day how many people died, how many people died, how many people died. And of course, what they aren't telling us, amongst other things, is that almost all of these deaths were occurring amongst the elderly. COVID actually starts to look like two diseases. It's not two diseases, but it starts to look that way because it affects the elderly very differently than it affects the young people. But the media is not going to say this. Why? Well, because that's better news, right? It's the bad news is here's all these people who are dying. So April to May, the media focuses on deaths, and you see if you break it down by age group, you can see how this varies. Now, the bars you're looking at, they're not deaths due to COVID. They're deaths due to COVID as a fraction of all deaths. So here's how you read this. Over on the right, you see the 85 plus. That's people who are aged 85 and older. Of all the deaths that occurred amongst that age group, 2.46% were due to COVID. So of all the deaths that occurred amongst the 85 and older group, less than 3% were due to COVID. And you look at the 75 to 84-year-old group. Of all the deaths that occurred there, about 1% were deaths due to COVID. And the numbers keep going down and down, and you can look at the young people, and the number of deaths are virtually they're not non-existent, but they're very, very small. In fact, if you look at the people ages 0 to 29, the number of people who died of COVID amongst that age group, that's 1/5 of the number amongst that age group who die of suicides. So let me say that again. Amongst young people, think school age, college age, amongst those people, 5 times as many die of suicide in a year as die of COVID. Not to say that COVID was not a threat to these people, but rather that there were other things that we live with on a day-to-day basis that were much, much greater threats. For example, we don't shut down our colleges. We don't go to remote schooling because of suicides. And yet suicides are 5 times. There's 5 times the number of deaths from suicide in this age group as there are from COVID. And so you can start to see this, the mischaracterization, our misunderstanding of the nature of the disease caused us to react in ways that, as you look back on it, were disproportionate. In other words, we acted toward COVID as if it were far more deadly than it actually was, at least for some people. And if you look at this chart shows you the deaths, the fraction of deaths in each age group over time. So it goes back to like March of 2020 all the way up to March of 2021. And you see that the dark red line, the big tall one, that's deaths from the people 80 plus years old. And then the pink dotted line, the 2 pink dotted lines below, that's people 65 to 79 and 55 to 64. So basically the dark red and the 2 pink lines, those are all people 55 and older. And what do you see with the green? The green is pretty much non-existent, right? It's pretty flat. That's everybody else. And this is this thing of COVID appears almost as if it were 2 diseases, something that's much more of a concern to people 55 and older, and something that probably isn't much of a concern at all to people younger. So this is April to May 2020. The media starts to focus on death. And then come about June to July of 2020, the deaths start to decline because we're practicing social distancing and we have the masks and all of this stuff, and we've shut down things. The deaths start to decline, and so they're no longer newsworthy. But the media has to do something to keep your attention. So they shift. And if you look at news reports back then, you'll notice this shift. In April, May, they're talking about COVID deaths, COVID deaths, COVID deaths. And then all of a sudden in June, July, they stop talking about COVID deaths and they start talking about infections. And the reason for the shift is that although the deaths were falling, the infections were rising. That is, the deaths were no longer bad news, but the infections were. So that's what the media started to report. And of course, to the casual observer who doesn't think much about this, saying, well, they said deaths here, and then later they said infections. The casual observer doesn't notice that. What the casual observer sees is this bad news, these exponential graphs, and this thing saying COVID's getting worse and worse and worse, and we have to do something. And of course, how do people react? They turn to their politicians and say, you've got to do something. Lock down the businesses, keep the masks in place, don't let people go back to school, all of this stuff. And then from August on, the media started to focus no longer on infections, but cases. And if you look at the news today, when you see COVID reported, they'll often talk about cases. And the reason they talk about cases are all the people who have ever had COVID, even those who have recovered from it. And the majority of people do recover from it. And the reason the media is talking about cases now is because the number of deaths has declined, the number of infections has declined, number of cases, well, that's everybody who has ever had COVID. Well, that thing keeps getting big because, well, it's all the people who ever had it. And so that's the last thing they've got to talk about that sounds like bad news. And of course, the perspective here is number of COVID deaths versus these other things. And I mentioned to you the heart disease and cancer together are twice the number of deaths of COVID. One of the counter arguments that people give me when I say that is they'll say things like, well, you can't compare heart disease and cancer to COVID because heart disease and cancer aren't communicable. You can't catch them from somebody else, but you can catch COVID from somebody else. And that's absolutely true. And that sounds like we should be more concerned about COVID, less concerned about heart disease and cancer. Except that argument cuts both ways. Because COVID is infectious, we can develop a herd immunity to it. Even without vaccination, we would develop an immunity over time. I mean, more people would die, but we would develop an immunity over time to COVID because it's communicable. Well, heart disease and cancer aren't communicable. And so we can't ever develop a herd immunity to them. And, and because of that, those heart disease and cancer deaths will persist. They'll keep on year after year after year, no matter what we do. Well, until we get some kind of cure for them. But COVID, even if we did nothing, we would have a few years of deaths of COVID, we'd develop a herd immunity, and then that would be the end of it until some new variant came along. So this mischaracterization influences our policy. Our initial goal was to flatten the curve, and then we the politicians shift from flatten the curve to no new cases. And if you look back in the media, you'll see politicians saying this, the same ones who said the lockdown is just for a couple of weeks to flatten the curve. After those few weeks go by, they say we're going to keep the lockdowns in place until there are no new cases. And then when we finally reached the point at which there were no new cases, they shifted again. And they said, well, we're going to keep the lockdowns in place until we have a vaccine. And then when we had a vaccine, they shifted again. And they said, well, we're going to keep the lockdown in place until we develop some herd immunity. And then finally we get Delta variant. And so we get the repeat of the whole thing, right? So my university went through all of this, and we had the masks and the remote learning and all of that. And over the summer of 2021, they said, okay, people are vaccinated now, and the number of deaths and cases have declined, and so we're going to be back to school as usual in the fall. And then along comes Delta, round about August. And what happens? The university says, oh, we're putting the mask mandates back in place, and there are going to be people who are logging in remotely rather than being on campus, and everybody has to be tested. And you can see we go back to this whole policy response again with the Delta variant. So that's kind of what's going on in terms of the information, in terms of the media and the policy responses. And all of this ends up having an effect, an economic effect. And so the question is, what is this? Well, first off, our unemployment rate jumped from 3.5% to over 5%. Our participation rate, which is a number you're probably not aware of, the participation rate is the fraction of working age people who are actually looking for work. And that dropped significantly. And if you let all the dust settle, that's about 8 million people out of work. The Congressional Budget Office estimates the cost of all of that over the next 5 years will be around $16 trillion. And when they say cost, what they mean is the lost economic activity. That our economy would be $16 trillion larger were it not for the lockdowns and all of the stuff that we did, our policy responses. So it raises the question, well, how many lives did we save? The Imperial College of London estimated that we were going to face 2.2 million deaths. We actually faced 648,000. So a reasonable person would look at that and say, well, look, the lockdown saved 1.6 million lives. The estimate was 2.2 million Americans would die, only 648,000 died. That's 1.6 million lives saved. Yeah, but here's the problem. The Imperial College of London, which was the major entity that conducted these studies, conducted similar studies for other countries. And one of the countries it conducted for was Sweden. Sweden is interesting because Sweden did not have a lockdown. The Imperial College of London estimated that Sweden would suffer almost 82,000 deaths without a lockdown. It didn't have the lockdown and in fact suffered 5,500. So what that tells me is the Imperial College of London overestimated the fatalities from COVID by a factor of 15. They overestimated Sweden's deaths by a factor of 15, which makes me at least wonder to what extent did they overestimate US deaths due to COVID? And perhaps the number of deaths we were going to face wasn't 2.2 million. Perhaps it was something remarkably less. But let's stick with the 2.2 million and let's take that as a worst case scenario. Worst case scenario, we would have faced 2.2 million deaths, and that means that the lockdown saved 1.6 million lives. Okay? We saved 1.6 million people. At what cost? $16 trillion lost of GDP, a third of small businesses permanently closed, And if you do the math, that means that each one of those lives that we saved, we did so at a cost of $10 million. Okay. Now, I'm not going to say that that's a good idea or a bad idea. The fact is, it's costly to save lives. What I do want to do is ask the question, how much do we spend saving lives from other things that aren't COVID? Well, there are some numbers on this. Smoke detectors, for example, save lives from fires at the cost of $14,000 per life saved. That's not $14,000 per smoke detector. It's $14,000 per life saved by smoke detectors. Improving rural roads save lives at a cost of about $250,000 each. Putting seatbelts on school buses save lives at a cost of about $5 million for each life saved. So these are things that we can think of in comparison. In comparison, all of a sudden, the cost of saving lives using a lockdown seems remarkably high. Now, you might still say, okay, but it's 1.6 million people we're talking about, and maybe this is worthwhile. Okay, but again, I ask you for perspective. 550,000 people die each year, or died in 1 year from COVID versus 650,000 from heart disease, 600,000 from cancer, on and on. There are all these other diseases that kill far more than COVID. Now consider this. Suppose we took that $16 trillion we spent fighting COVID to save lives from COVID, and instead we spent it attempting to save lives from heart disease, cancer, and Alzheimer's. What could we do? Congress currently spends $6 billion for cancer research and for the National Cancer Institutes, and another $39 billion for the National Institutes of Health. For $16 trillion, Congress could have increased NCI and NIH's budgets by a factor of 300. And for a factor of 300, I'm pretty sure, not even being in the health industry, I'm pretty sure we could have cured cancer and heart disease. And we would have saved far more lives than we saved spending that $16 trillion on COVID. Now, I'm not suggesting we should spend the $16 trillion. What I'm saying is, again, we come back to the situation of it appears that we acted disproportionately. If we're not willing to spend $16 trillion saving people's lives from heart disease, cancer, and Alzheimer's, then there's no reason why we should have spent $16 trillion saving their lives from COVID, because we could save a lot more spending it on heart disease, cancer, and Alzheimer's. And this brings me to the conclusion. The conclusion is that we appear to have overreacted to COVID, starting with the lack of information, which was picked up by which tells us bad news. It doesn't give us context. And the politicians now have to react to what the media has said, because what the media says is what the voters start to believe. And if the politicians don't act according to what the voters believe, the voters get quite irate. And so the conclusion here is this is what happens when you politicize healthcare. When we leave healthcare to be healthcare decisions to be made by the media, to be made by voters, to be made by politicians, you end up in a situation like this where you have acted disproportionately.